Well, hi, everybody. Can you all hear me? Thumbs up. Awesome. I want to welcome you to our Grand Rounds 2020 on this Friday the 13th. That's a little nerve-wracking. So, Gloria, what were we thinking? Friday the 13th in the year 2020.
I don't think we knew 2020 would be this way when we
But here we go, and we're so welcoming today, and so glad that you guys are here, and we're going to have a great discussion. We want to give some thanks to some people, Gloria Burnett and Carrie Ann Shine, who are on the background here helping with the technology. Appreciate you. We have some facilitators helping us today when we get into our small groups, and we thank you for joining us. And then we have some panelists, some experts that have joined us today, and are very, very grateful that they are willing to help Alaska out and give some education for us. And so I'd like to introduce them to you. If you didn't see their bio sketches, I'm going to run those through right now. So Dr. Maya Artandi is an associate professor of medicine in the Division of Primary Care and Population Health at Stanford. She's a leader in primary care, spearheading the novel methods of healthcare delivery and education. Her expertise lies in the development and implementation of a medical curriculum focused on the patient-physician interaction, emphasizing communication skills, physical examination skills, and medical decision-making to support best clinical practices. At the beginning of COVID-19, she was instrumental in the rapid conversion of in-person visits to Stanford Primary Care to telemedicine visits, and has been teaching nationally on how to best perform telemedicine exams. Under her leadership, Stanford started one of the first drive-through COVID-19 testing stations in the country. She also started and is directing the Stanford Outpatient COVID-19 Clinic. She's the co-director of primary education for Stanford Internal Medicine Residency Program. Welcome, Dr. Artandi. We also have Sarah Afromowitz, and Sarah is currently a fourth-year doctoral student at Pacific University in Hillsboro, Oregon. She earned her non-terminal master's degree in 2019 and is expected to graduate with her Doctor of Psychology and Clinical Psychology in 2022. She has clinical training experience working with patients of all ages on interprofessional teams as a behavioral health consultant and mental health provider in family medicine practice, community mental health clinic, college counseling setting, and the VA. Due to the COVID-19 pandemic, she transitioned to providing telehealth services to all her clients, where she has provided therapy and conducted assessments through video sessions. Her research interests include trauma, compassion fatigue, preventive mental health care, diversity training for healthcare providers, and program development for suicide prevention. Welcome, Sarah. We also have Dr. Heather Wiggins. Heather has been in the healthcare environment for 25 years, where she started out as a certified nursing assistant, and while she was finishing her bachelor's degree in nursing, and I know we have a lot of nurses working on their degrees right now that are present at this event. She graduated with her bachelor's in nursing at the University of Wyoming in 1998. She then worked as a registered nurse for 18 years in a variety of settings, including acute care, school nursing, public health, and travel nursing, prior to finishing her master's degree in nursing in 2014 and a doctorate of nursing practice through the University of Arizona in 2016. She has always worked in rural settings and has been a primary care provider and family nurse practitioner for the past 6 years. She began her primary care career in Wyoming at a rural clinic and moved to Oregon in 2017, where she's been a primary care clinician in rural Northeast Oregon. She's currently the director of the Eastern Oregon University Student Health Center and assistant professor at the Oregon Health Sciences University School of Nursing F&P DNP program. Her interests include the utilization of interprofessional teams in primary care, and most recently, the use of different telehealth modalities to increase access to care in rural settings. Welcome, Dr. Wiggins. And Dr. Wiggins, am I right that you also had some grant money to help with telemedicine?
Yes, Megan, actually, Dr. Hagen, who you are all blessed with now as your Dean of the Nursing School at University of Alaska, she had written a grant before she left here. And that grant, the purpose of that grant was to purchase telehealth equipment in order to train undergraduate nursing students in the use of different telehealth modalities, and also some of our preceptors. And so we're in the process of developing training modules and also a simulation for our undergraduate nursing students.
That's awesome. I love it. Thank you for sharing that. So we're going to get going on our presentation here. I'm your MC today, Megan Volkov, and I'm an assistant professor of nursing at UAA, and I also sit on the committee for the interprofessional education through the College of Health. And again, we welcome you. So Carrie Ann, I think we can go to the next slide. So why telehealth for infectious diseases? Well, I think we all know the answer to that. And I think that word is COVID. But telehealth has been around for a long time, way before COVID, but COVID's kind of brought out its importance, and it's brought out a lot of importance about the technology that we use. If you go to the next slide. So this Grand Rounds, this is only part one. So fall 2020 is part one, where we focus on telehealth. So the technology, what is it? How do we use it? Go through a case study together. And then in the spring 2021, we'll have part two, and that will add the topic of infectious diseases and the use of telehealth. We can go to the next slide. And to introduce telehealth to you is Dr. Artandi, and take it away.
All right. Hi, everybody. I'm really excited to be here. I would be even more excited to be there in person.
Dr. Antandi,
Yeah.
your volume's super low.
Oh, darn it. Oh,
That's
goodness.
much better. Whatever you
Okay.
did, fixed it.
I'm going to get very close to the screen. Sorry, you'll see my face very big. So I'm super excited to be here. I would be even more excited to be there in person because I always wanted to come to Alaska. It's totally on my bucket list, and maybe one of these times I'll come. So thank you so much for having me. And I'm going to talk to you about telehealth. Next slide, please. So question is, what is telehealth? And telehealth is the healthcare delivery via video, but also via telephone. So two measures. At Stanford, this time last year, we barely did any telehealth. I would say about 95% of our visits were traditional in-person visits, very few telephone visits, and even fewer video visits. And then the end of February, beginning of March, the pandemic happened, the Bay Area surged, and suddenly we had to deliver healthcare in a pandemic. So the question was, how do we do that? How do we protect our patients who need to come in for chronic healthcare maintenance, like diabetes, high blood pressure problems, without exposing them potentially to COVID-19? How do we take care of patients who might have COVID-19, the so-called PUIs, patients under investigations, because they also needed to have healthcare? And then how do we protect our staff, our providers from getting sick with COVID-19? And the solution to that was telehealth. It's super safe to provide care through a screen because you don't get exposed to anything. Next slide, please. So it's not as easy as just calling your patient up and FaceTiming with them. There actually is a lot of work that goes into developing a telemedicine program. The first thing that you need to have is a digital platform. This digital platform needs to be HIPAA, meaning patient safety and privacy compliant. It also needs to interact with your electronic medical record. And then the next thing is you need to have IT support. So those things you would never think about when you do in-person visits, because when you see a patient in the clinic, you don't need IT because the patient is right there. But if you interact with a patient through a video, you do need IT support, because there is nothing more frustrating than when you're ready to see your patient and suddenly the internet cuts out, or you can't hear your patient, or you can't see your patient. So you need to have IT support on site, readily available, and they need to know what they're doing. The next thing is that you need to train your providers. In medical school, I didn't learn anything about virtual medicine because it wasn't a thing then. And now suddenly we are all virtual, and our providers didn't know. They didn't know what to do through the telehealth. They didn't know how to do a physical exam. So training the providers, I'm also really involved in training the residents. So training the residents how to do that is really important. We don't yet have good quality control measures for telehealth. There's some anecdotal evidence that providers through a telehealth visit will prescribe more antibiotics, even if they're not indicated, because they just don't feel as safe. They can't listen to the patient's lung. And then when in doubt, just give the antibiotics. Maybe you will miss the pneumonia. So we need to develop quality control measures for telehealth. We need to train our medical assistants. Our medical assistants also didn't really know much about virtual health. They didn't know what their role was, because you initially don't really need a medical assistant. You can just, as a provider, talk to your patient through the screen. The patient does not need to be roomed, doesn't need to be vital. So what is the role of the medical assistant, and how can the medical assistant add to the visit? And we figured that out. Now our medical assistant actually pre-room the patient. They do all the population health questions. So they have a big part in the virtual visit. Patient education is crucial because, again, the patients weren't used to doing telehealth visits. So they need to be taught how to log onto the system, how to be in a safe environment, have good lighting, have good internet access. And the last thing is patient scheduling, because not all patients are adequate and appropriate for a telehealth visit. Next slide, please. And so I'm going to tell a little bit more about the scheduling. And here you see our decision tree for scheduling telemedicine visits. So patient calls the clinic for an appointment, and we have a central call center, and this call center schedules all patients for appointments in clinic. So the patient call is transferred to that call center, and then the call center people have to decide, is the patient dying or not? Is the patient really sick? And they're doing that with a so-called hot list. And the hot list items, for example, are acute chest pain, severe abdominal pain, severe shortness of breath, acute neurological symptoms. Is the patient suddenly not able to move one side of their body? Severe psych problems. Is the patient safe, or does the patient want to harm themselves? If the patient has any of those hot list items, there will be a warm handoff to the triage nurse. And the triage nurse immediately talks to the patient and then makes a decision. Does the patient need to go to the emergency room, or does the patient, can the patient schedule a clinic visit? Because not all chest pain, for example, are heart attacks. If you have your 23-year-old who's completely healthy, no past medical history, no family history, had a super spicy meal the night before, that chest pain is probably just heartburn and can be evaluated in clinic. Now, if the patient doesn't have any of those hot list items, then the people in the call center ask the COVID questions. And as you know, pretty much everything nowadays can be COVID, so it's hard, but some things are more common in patients with COVID-19. So the questions they ask are, do you have a cough? Do you have a sore throat? Do you have a fever, a headache, loss of sense of taste or smell? And or have you had contact with anybody who had confirmed COVID-19? Now, if the patient says yes to any of these things, they can't come to clinic. They need to schedule a video visit, and the call center is going to help them with that. If the patient says no to any of the COVID questions, then the patient can either be scheduled in express care or in primary care. And there are lots of visits that the patient can come in for. For example, if they step in a piece of glass and need their laceration sutured, they can make an appointment with express care and then get sutured. Next slide, please. You can probably imagine that there are lots of advantages for telehealth. Number one, it improves access to care.
Dr. Condi,
Yeah.
your voice went out a little bit again. Just wanted to.
Oh, okay. Coming closer to the screen again. Sorry. So it improves access to care. I have patients who drive 3 to 4 hours just to see their providers at Stanford. So they pretty much spent the whole day just to come to an appointment at Stanford. I have patients who can't drive and they're always relying on someone else, on their family member. So they can only come to appointments if the family member has time to drive them. With telemedicine, they can have their appointments from home. So it really improves their access. As I mentioned before, telehealth really prevents disease transmission. We can wear as much PPE, personal protective equipment, which really is uncomfortable to work in, I'm telling you that. But telehealth is the best PPE at all because you are not even exposed to the patient at all. So it does prevent disease transmission. It makes it much more flexible for providers to provide care to their patients. I would have never even dreamt of the possibility that I can work from home as a physician. But now, some days, I only have video visits scheduled. So I log in from my computer from home and I work at home. And in my lunch break, I can make lunch for my kids. So it's super flexible for us. Next slide, please. It is also really convenient for the patients. For a normal in-person visit, the patient has to take off work, has to find a babysitter or someone to watch the elderly in the house, then drive to the appointment, park, sit in the waiting area. Takes a long time, very inconvenient. Nowadays, you can just log in during your lunch break. Your kids can play in the background, so you don't need a babysitter. So it's super convenient for patients. Another nice advantage of telemedicine is you can assess the patient's environment. You can get a glimpse on how the patient lives. You can look at their house. You can meet their family. You can meet their pet. You can look at their yard. And what I also think is super convenient is you can do medication reconciliation. What that means is that every visit, we ask a patient, which meds are you taking? And you would be surprised, but most patients have absolutely no clue what they're taking. And most of the patients forget to bring their medications to a visit. And then you're stuck. You're like, well, I prescribed you the blood pressure medication. I don't really know if your blood pressure is high because it's not enough or you are not taking them. So if you do a telemedicine visit, you can just tell the patient, please go and get your meds from the bathroom or wherever you store them. And then you and your patient go through the meds together. And then you know what they're taking. So that is really, really helpful. And then you are able to monitor the patient's health at home. In the COVID clinic, we risk stratify our patients into low risk, moderate risk, and high risk. And for the moderate and high risk patients, we send them oximeters so they can check their oxygen saturation at home. And when we call them, we always ask them, what's your O2 sat? And I have sent several patients to the emergency room when they were admitted because the O2 sat suddenly was less than 90%. So that's super helpful. I know there are many companies developing kits to even improve the home monitoring. There will be stethoscopes that can be linked to the virtual platform. So you can actually listen to the patient's heart and the lung sounds. That's in the works, not there yet, but I think the future means that patients can be kept longer at home or be discharged from the hospital earlier because you have the ability to monitor patients' health at home. Next slide, please. So you would think telemedicine, fantastic, all rosy. Let's just convert everything to telemedicine. But unfortunately, there are some disadvantages. So number one, you are dependent on the technology. And if there are technological glitches, you can't really do your medical care. If you can't hear the patient, if you can't see the patient, if the internet cuts out, or in my case, if you can't hear me, totally annoying. So you are dependent on technology. Also, telemedicine sometimes is not fair. There are people who don't have access to the technology or they can't use the technology. People who don't have the ability to have good internet connection. People with disabilities, if you have visual or auditory disabilities, it's much harder to use telemedicine, mental disabilities. All these people have disadvantages for telemedicine. Telemedicine is also not cheap. You have to provide the platform and you have to have the IT support. So that might be a problem for smaller clinics. Next slide, please. And many of our patients, especially the elderly one, were really not comfortable with the technology. There is the barrier. Oh, I don't want to use the computer. I don't feel comfortable. I don't know how to do that. It was actually such a problem that we created a course for our medical and undergraduate students with a goal for them to help our elderly patient or people who were not comfortable with the technology to understand how it works, to explain how to log on, and to take a little bit away the fear of the, oh, that's the computer, I don't like it. And then, as I mentioned before, it is much more difficult to perform an exam. A colleague and I made several videos on YouTube how to do a video exam, but you are reliant on the patient to help you. So we called it the provider guided patient self-exam. And what you as a provider have to do is you have to walk the patient through exam maneuvers. Sometimes it's easy. Sometimes you can just tell them, look in the back of your throat, describe what you see. Are your tonsils, the little things in the back of your throat, really big? Do you see white stuff on them? Feel your neck. Do you feel any lumps or bumps? Does it hurt? Sometimes it's a little bit harder. For example, when I do a telemedicine shoulder exam, I have to walk the patient through the different maneuvers. Best, easiest ways if I just demonstrate. So some days I'm super active through telemedicine because I have to demonstrate all my physical exam maneuvers. And then, as I mentioned before, quality control is not yet established. We are working on it, but we need to figure out the rate of unnecessary antibiotics. We need to see how good those physical exam maneuvers are through telemedicine. Next slide, please. So, concerns with telemedicine. Can we ensure privacy?
Dr. Arsandi, happening
Oh, no.
again.
Darn it. Terrible
It's
computer.
perfect. It's an example of the short
Yes, it's a terrible example. I'm so sorry. So can we ensure privacy? Meaning, is the platform we use safe or can someone hack into it? I'm still uncomfortable doing a genital exam through virtual health because it's just, I don't know. I mean, I know our platform is secure, but for the patient, it is a big deal. Is the patient in a private area? So some patients do the telehealth in the middle of their crowded office. And then if you have someone with a genital rash, they will not tell you about the rash and they will not tell you why they might have the rash. So privacy is a big thing. Then is there focus on technology rather than the patient? So if the technology works without a glitch, it's great. If you can't hear the patient, like you can't hear me, then it's like I'm struggling with how to overcome that barrier and I might not concentrate as well on the patient as I should. Can we really connect with our patients? And I'll give you some tips a little bit later on how to accomplish that. And then how do we do a physical assessment? And there are still a lot of uncertainties on what works and what doesn't. Next slide, please. So here are the promised tips for how to improve your connection with the patient. And honestly, I don't use these tips only for telemedicine. I also use many of those for my in-person visits. So the first thing is I work in urgent care most of the time, meaning I meet a new patient every 20 to 30 minutes, a patient I've never seen in my life. It's really important that before I walk into that room that I am familiar with the patient. So I read the chart, I read the last couple of notes, I read the past medical history. So when I come in there, I know what the patient has. I know, for example, if the patient has cancer or had several heart attacks. Really important, also really increase the trust the patient has in you. Another thing, this is just for telemedicine, look the patient into the eye, which means you look at the camera, you don't look at the patient's picture. If I look at the patient's picture on the screen, the patient will see my forehead, and that doesn't really work. So look at the camera. Sometimes it's a little bit hard. So the trick I use is I pull the patient's picture all the way up towards the camera so I can look at the patient's picture and the camera at the same time. Introduce yourself to the patient if you don't know the patient. And that seems obvious, but if you spend the last 10 minutes going through the patient's chart, you feel like you know the patient. And then you don't feel like, oh my God, I need to introduce myself, but the patient has never seen you. So it's really important that you introduce yourself. And sometimes I have learners in my room. So I always make sure that the patient knows everybody who's in the room with me and is comfortable with also meeting other people. And then sometimes I have to chart, I have to put orders in, so I cannot look at the patient all the time, but I tell the patient what I'm doing. So the patient understands that, no, I'm not bored and I'm not disinterested. I'm just working on their behalf. Next slide, please. Again, make sure that the patient is in a place that works for a video visit. Ask the patient if they're in a private place. And if not, they should reschedule. I also had patients initially who were driving while they're having the video visit, which is absolutely not safe. So you need to ask the patient to pull over or reschedule the video visit. Next thing that is really important, not just for video visits, but if you see a patient anytime, listen intently and completely. So what I do is I introduce myself and then I ask, how can I help you today? And then I just let the patient speak. And after the patient is done telling me why they're coming in today, I repeat to the patient what they told me and inviting them anytime to interrupt me if I forget something or got something wrong. This way the patient knows that I listened and that I understand their concern. Explore emotional cues. It might be a little bit easier if the patient is in the office. If someone starts crying, you can hand them the box of tissue. You can put your hand on their shoulder, all these things. So physical connection helps a lot with that. What you can do through a video visit.
Your audio cut out for me. Did it cut out for anybody else?
Yeah, I'm not hearing you, Dr. Atandi.
Still not hearing anything.
Did you have an external microphone hooked up to your computer? Did you connect to one? If you hit your microphone settings, does it show that it's connecting to a speaker or another microphone? Because you're not showing that you're muted. Oh, now you are.
I think she might have just hopped off, and so maybe she'll get back on.
Yeah.
I will use this as a friendly opportunity to make sure I have registration information from some of you folks. So if you haven't done so already, one of the things that will be helpful is for you to change your name in your window of your Zoom call. If there's the little dot, when you look at your picture or your name, you can hit rename. And and then it'll allow you to put your full name. That's going to really help me when I register you all to breakout groups a little bit later. Also, if you have not already registered, I will be reaching out to you in a chat box message. So please be aware of the chat box because I'm trying to collect everybody's majors so that I can get you all organized in interprofessional groups. So just a couple of little housekeeping items while we wait for Dr. Artandi to get back on.
Also, if you called in, I don't know if you can chat or if you can email me and let me know who you are so I can count your registration and we can break you out into groups as well.
Would it be helpful to go forward a slide or two and have Sarah or, well, maybe not. Maybe we'll just wait.
I'm back. I'm so sorry. I have a really old computer, which tends to shut off if I don't move the mouse. So good example for computers not working. I'll talk to IT. So I really apologize about that. So we were at emotional cues. So for a video visit, if you see that the patient is sad or if the patient is angry, mention that. Talk to the patient, say, hey, listen, you seem sad or angry to me. What's happening? What can I do? And the patient appreciates that. And then the last thing is that helped me a lot is notice the patient's environment. Notice that the cat is walking by and ask about the cat. I had a patient who walked me through her yard afterwards, the video visit, and showed me her flowers. And that really increased our connectiveness. So next slide, please. All right, let's walk through a patient case study just to make you understand what it is like. And this is a fictional case, but I have seen patients like that through video visits quite a bit. So you have your 82-year-old patient who presents for a video visit, and she scheduled the visit because she is not feeling well. You review her chart and you notice that she has a history of diabetes mellitus, heart disease, and high blood pressure, and she takes medication for all of these things. She has not been feeling well for 5 days, and she's actually getting worse. She normally lives by herself. She's quite independent, but because she's sick, her daughter asked her to stay with her. So right now she's living in her daughter's guest bedroom. Next slide, please. So the patient says her symptoms are cough, fatigue, and shortness of breath. And now we examine the patient, and I am a huge fan of something called eyeballing. Within 5 to 10 seconds, I can often, actually most of the time, tell you if a patient is sick and needs to go to the hospital or not. So that's very nice, and you can use that also in a virtual visit. So when you look at this patient, what you notice first is that she is lying in bed. So that gives you a much higher level of suspicion that she's really sick than if she would be walking around, being in her car, being at work. So she's actually lying in bed. What you also notice is that she has 3 pillows underneath her. So she doesn't want to lie flat. And people who have problems breathing often don't want to lie flat. They want to have their head up a little bit because that makes it easier for them to breathe. One clue in this picture is that we're having an inhaler. So that tells me also that she is short of breath. And then I just watch her breathe. And you probably know that the normal respiratory rate for people is about 12 times per minute, but she is breathing fast. She's tachypnic. So she goes, and that also tells you that she is short of breath. So she is panting. When she talks to you, she is not able to speak in full sentences without interruptions. So she talks like that because she can't really get a word out without taking a deep breath. And that's a really helpful sign. Sometimes people don't really understand they're short of breath, but if they cannot speak with you without taking deep breath every 2 to 3 words, they are short of breath. And then she interrupts with a cough, and the cough is a wet sounding cough. So it sounds a little gargly, not like this dry upper respiratory cough, but she has a wet sounding cough. Next slide, please. So in your assessment, in your summary, you say you have an elderly woman with respiratory failure. And you notice that I didn't put a diagnosis on this. Respiratory failure is a purely descriptive term. And the fun thing of urgent care and primary care is that most often a patient walks into your office and you don't know what they're there for. They have a complaint. And a common mistake that my learners often make is they narrow down, they say, oh, this is this. And then they forget all the other things that it could be and don't ask the right questions, because often it is not the first obvious diagnosis that you think about. But if you don't think about other diagnoses, you won't evaluate them. And then that leads to delay in therapeutics. So in her case, she might have COVID-19 because we are living in the time of COVID-19. She might have bacterial pneumonia, but she also might have heart failure because heart failure can present just like that. So what do you do? Personally, I would not feel comfortable at all having this patient stay at home. She's elderly, she cannot breathe, and she's getting worse. So that patient needs to go to the hospital. So I will tell her, go to the emergency room, call a 911 or have your daughter take you. And then I will call the emergency room to tell them that the patient is coming, tell them what I think it needs to be done. And this patient most likely needs to be admitted for better care. Next slide, please. And now I'm handing it over to Dr. Wiggins to talk to you about the role of the provider.
Thank you, Dr. Artandi. It was wonderful learning from you as well. It's an honor to be here with all of you. And I was asked today to talk about my experience as a provider in a rural setting with telehealth. And I will be honest with you all, I actually am quite a novice with telehealth. My experience with telehealth prior to COVID-19 was as a consumer of telehealth. My daughter is a cancer survivor, and we live about 5 hours away from OHSU Portland campus, where she receives a lot of her care. And so we have had a lot of experience with telehealth talking to specialty providers, and that's been amazing to not have to drive that 5 hour distance. And there's quite a lot that you can do with telehealth. I love the World Health Organization's description of telehealth as healing from a distance, because it truly can be in a lot of instances. And I think, as Dr. Artandi pointed out, that there is a large role for triage in telehealth and trying to make good decisions about the next level of care. And so my experience with telehealth now with COVID-19, I was working, or I am working still, as a family nurse practitioner at our small student health center here in Eastern Oregon. We have a campus of about 1,500 students, and our clinic is really just myself 20 hours a week, and then another nurse practitioner 20 hours a week. We have a receptionist and a part-time clinic manager, and we don't have a medical assistant or a nurse here. And we quickly discovered with the pandemic that we needed that role. We needed someone as a triage nurse answering some of the phone calls that we were getting from students who were very concerned, anxious, nervous about what was going on, and didn't necessarily need to be seen at the clinic, but needed some reassurance and some education about what to look for with COVID-19 symptoms. At that point, early on in the pandemic, we really didn't have much testing capability here in our little clinic. And so that became a huge role for us to use telehealth to talk to the students and try to determine if they needed to be seen or if we could monitor them frequently at home. And so we used WebEx, which is similar to Zoom meeting. OHSU uses WebEx for telehealth. And so the way we would connect with the students, we would email them a link to join with WebEx, to join us with the WebEx meeting. And then one of the providers would visit with them. At the beginning of the pandemic, we did have a nurse who helped us out, who volunteered to come and help us out with some of those phone calls to determine if the students needed to be seen or not. And that helped a lot. And similar to what Dr. Artandi was talking about with the hot button symptoms, those are the questions that she asked those students. As the pandemic became, I guess as we were able to provide more care and we had other options and the ability to test, we started seeing more patients in the clinic again. And as we had appropriate PPE to do that. But we still use telehealth and offered that as an option for students if they didn't feel comfortable coming into the clinic. There are a lot of things that you can do through telehealth, such as anxiety, follow-up, depression follow-up, medication management follow-up, and chronic condition follow-up. And so a lot of those follow-up visits were done through telehealth, and that helped a lot, I think, for students just to have that connection with someone that they knew they could talk to if they needed reassurance or guidance. And then, of course, the triage nurse would decide if a student needed to be seen here at the clinic. And then now what we have done at the Student Health Center, now that we have more testing capability for COVID and adequate PPE, we have a case management team that we have built with different roles at the university. So on the case management team consists of myself and the other nurse practitioner here, our counseling center staff. We have 2 psychologists that we're very blessed to have here. We also have some athletic trainers for the athletes who are very involved in the students' care. We have a COVID response nurse who we were lucky enough to have join us, and she is actually a public health nurse. And so that was amazing to add her to our team. And then we have members of the student affairs team to help students if they're in isolation or quarantine, to kind of serve as case managers to help them get what they may need at home if they're stuck at home in isolation or quarantine. And so the role of the nurse that was hired, she is actually doing telehealth visits with students who are in isolation or quarantine to monitor their symptoms if they're having severe symptoms. And we do loan out pulse oximeters for some of the students who are having those more severe symptoms. And so then she can meet with them and triage and then decide if they need to be seen in the ER or if they can come in and do a clinic visit with us. So that's my experience with telehealth so far at our little rural student health center.
Thank you, Dr. Wiggins. I appreciate that. And can we move to the next slide? And Sarah, I was hoping you could take over about a little bit more about interprofessional, if you don't mind, and if the role of that patient and family member.
Yeah, absolutely. Can we actually go back one? Yeah, to that one. There's a few things that I wanted to hit on this that some of it has been covered by both Dr. Artandi and Dr. Wiggins. You know, the confidentiality piece and the environment. But with the interdisciplinary teams, the spring when I was working at the behavioral health, as a behavioral health consultant at the family medicine practice, that's when we transitioned to telehealth, and holistic and collaborative care was still our priority for providing patient care. But it was also a lot harder because we weren't all in the same location. So, the warm handoffs that I used to provide for patients became a lot more challenging. I couldn't just talk to the provider, couldn't come find me and say, hey, this is what's going on with this patient. Could you come talk to them? Those debriefs weren't as natural, and I couldn't just stop by a patient's room anymore. So it became a lot more intentional. And I found that collaborating with providers really took that extra effort. And so that meant, sending a lot more emails or chart messages, reading each other's notes just to stay informed before seeing a patient. And also the piece of, continuing to screen for mental health concerns like depression, anxiety, and suicidal ideation really needed to continue, because that was something that some of our medical providers felt a little bit more uncomfortable with because the mental health providers weren't on site. But it still needed to happen. And so we found a way to make sure that our providers were still doing that piece so that our patients could be looked after in an appropriate way, especially during COVID season when people are a lot more isolated and feeling a little bit more anxious and scared. And so even though you're not in the room there, it was important to kind of talk to providers about how to create a safety plan that was going to be more creative, and communicating risks needed to be a lot more routine across all providers. Something else that's not on this list is that it's really important to continue to engage in self-care as a provider. I think that's something that we hear often. I think especially as students, I, as one of them, is hear often like, self-care, and that's kind of given a little bit more lip service than I think it deserves. But as this could be different for different professions, but as a mental health provider, I often have difficult conversations in my home, with the patient, talking about trauma or talking about other difficult conversations. At the end of the day, like, I'm still in my living room, and I don't have that ability to transition to work and home from work as I used to in person. So I think it's really important to, be able to monitor that and be able to think about, have you gotten up and moved around recently? Are you still taking care of yourself? Are you drinking water? Are you eating throughout the day? How do you have some sort of routine to transition? Because I think it's really challenging when everything is happening in your home. Those boundaries kind of disappear. Okay, you can go to the next slide now. Okay, so the role of the patient and the family, is similar to the provider. Patients also have a role in maintaining confidentiality. One thing that we ask all of our patients to do is to let us know if somebody else comes into the room. I can't tell if somebody's on the other side of the camera, in front of the patient. So it's important to know who's in the room when you're talking to them. I have had a number of clients who, because their parents or they have kids at home, they didn't have a place to go for a private conversation, and so they would go to their car and parked. They'd sit in their car and have a session from their car. That was a great creative thing if that worked for them. Other roles is that, as some families use shared devices, so it's important to schedule a time when no one else is going to be using that device so that you can use it uninterrupted, and the family can be respectful of that, as respectful as possible as that time. And then depending on who the patient is, families might be more actively involved in sessions. Working with kids, I need an adult there, to make sure that they can get into the video session and to give me updates in terms of what the issue is that week or any progress, and then also be available for goal setting and checkout at the end of the session. And then I also want to talk a little bit about health literacy here too. It's important, both for in-person and telehealth sessions. But with telehealth sessions, we have this unique barrier of not being in person. And we know that our patients are likely to say that I understand everything, even if they don't. And patients really go at great lengths to conceal their lack of understanding. So the unique barrier of the internet connection also kind of plays into this. When you're explaining something that's important and your internet's going in and out, that's going to be really frustrating for your patients and might create some sort of disconnection. Even if you're looking into the camera, just as Dr. Artandi was talking about, it's still really important that you can try to read their body language, even with this barrier of videos rather than in person. And using that same level of plain language and clear communication and not overloading information, just easier to do when there's that disconnect of the camera. You can't really get their feedback. So it's again, the summarization at the end of the appointments and using the teach back method, where you ask patients to summarize in their words what their understanding of their health and what you ask them to do. But of course, telehealth offers more flexibility. Again, as Dr. Artandi and Dr. Wiggins were talking about. However, there are also downsides of the telehealth, right? And which includes technology can be a barrier to establishing rapport. And using telehealth requires that individuals have access to technology. When I transitioned in the spring, a number of my patients were like, I don't have a computer, or I don't have something that has a video camera. Like, what do we do then? And so being creative or using, people don't have Wi-Fi, things like that. Using phones is not obviously the preferred method, but may need to happen. All right, that's all I have.
All right, next slide, please. All right, we're going to be breaking into smaller groups now. And Gloria, do you want to explain a little bit how that goes?
I think I need a little bit more time. There's a
little bit. All right.
Thought there would be. If you can just maybe have some open discussion or Q&A right now to
Absolutely.
great.
Well, why don't we open it to some questions? Does anybody have any questions for Dr. Artandi or Dr. Wiggins or Sarah?
Yeah, I have a question. So as you guys mentioned, hi, my name's Sherry, actually. Sorry, I don't know you. I'm here in Anchorage. You guys mentioned working with rural communities. Have you found that you've used maybe these kinds of telehealth resources but without video, and how has that worked for you guys? Because I know some people just don't have the capability, or maybe they don't own something that has a good video connection, or they don't have internet for that. And how has that worked for you guys? Just doing, like, I guess kind of a phone call doctor's appointment.
So we do that quite a bit, especially with our elderly patients who don't feel comfortable. I don't like it as much because I can't eyeball someone through a phone call. So it is much harder. But yes, some of our video visits will get converted, or they are phone calls, and then you have to deal with that. But again, for me, I prefer to do a video visit.
And I would agree. I've had to switch to telephone a lot of times because of difficulty with broadband in rural areas. And so it's not quite as informative. Hopefully you've had enough, that first few minutes to do that quick general survey of your patient, and then you can switch to telephone. But definitely telephone, you can do telephone encounters.
I was just going to ask, I'm Marlo, by the way, if with the telemed, have you found that patients aren't as open about things as if they were in person? Like they just don't disclose as much? Found like a difference in that, I guess.
Definitely possible, especially if the patient is not in an area where they can share private information because they didn't plan ahead. So then you're stuck with, they're not giving you the information they need. But sometimes I'm surprised how much they actually are able to share in a virtual visit.
Yeah, I'd agree with what Dr. Artandi said. I think that's certainly true if they're not in a private space where they can share. But on the other side, people tend to be more comfortable when they're at home. And so they might share things that might feel scarier because there isn't this person in front of them.
We have a question here on the chat regarding physical exam. Can we go through some body systems that we can definitely do over the video with the patient? Ooh, this is a good one, Dr. Artandi.
Oh, I love it. That's totally up my alley. And if you want to see some examples, if you just you can Google me and then go, and there we did some actually quite good YouTube videos. So for example, initially when I started, I was like, well, there's no way I can do any musculoskeletal exams through the video. But you can actually do, for example, the shoulder exam. You can always, even in person, especially in person, make the patient expose both shoulders so you can compare. Then you can have the patient palpate and say, oh yeah, it hurts right there. Then you do your range of motion. And even in person, I always tell the patient, I always show the patient, because explaining to the patient where you want to move, have them move their arm, it's really hard. So then you just have them move their arms around. So you see if they can move. And that already gives you a hint. If the patient doesn't want to really move the shoulder, that tells you. And then you do your provocative maneuvers, and you can walk your patient through that. So that gives you a pretty good idea. Another good example, for example, is the neurology exam. I can do a pretty good neurology exam through the virtual visit. I can do almost all the cranial nerves. I can do coordination. I can do strength. I can do coordination. I can do walking, gait. So there are lots of things you can do.
I had a question about, this is Lacey. I'm with the Fairbanks cohort for the nursing school, School of Nursing, excuse me, with UA. I was wondering about the current providers and how that is being addressed with their training, and kind of the idea like teaching the old dog new tricks, like that concept. Some of the providers I work with are quite a bit older, and I just had to switch over to a new software program for our clinic, and it was quite interesting trying to get them to learn to adapt to it. Is this almost kind of causing issues for older providers, or just people that are maybe not as technically savvy?
Oh,
fortunately, it's not that hard to do a video visit. For us on the schedule, you just click on the camera and then you're in the video visit. And when you have issues, you call IT. When we switched to the EMR 12 years ago, that was a much bigger lift. But video visits is the camera turns green when the patient shows up, you click on it, you're in the video visit. So it's quite easy.
And I was going to add that with our family nurse practitioner students, we have actually done some virtual simulations through WebEx or Zoom using standardized patients, and a case study similar to the case study that you all looked at, but having a standardized patient there, a patient actor for the students to practice getting a history from. And I think that's a huge issue too to talk about. 90% of your diagnosis you can get from a really good history, a very thorough history. And so that's been helpful for our students. And then also practicing some of those exam techniques over WebEx with a standardized patient as well.
yeah, thank you for mentioning that, Dr. Wiggins. We did that with our F&P students. We did a telehealth simulation, and they had to do some pretty good history. Didn't do as much physical exam. So what we ended up doing in our debrief later on is we sent Dr. Artandi's YouTube of like, look, you can do some physical assessment through the computer, and it's really pretty eye-opening. I certainly learned. I thought you could never do that, and you can actually do quite a bit of a physical exam, which is pretty exciting. So thank you for mentioning that. There's another question here. Have you noted an improvement in wait times and appointment time management on telemed?
Okay. It's much easier. So you run much more on time if you do telemedicine. What we have noticed though is that patients hate to wait in front of their computers. So initially we tried to have in-person and telemedicine interspersed, and that didn't work because for the in-person you tend to run a little bit later because the patient is like, oh, by the way, I have chest pain. And then you're stuck because you can't just say, oh, goodbye, talk about it next time. So what we do now is we have telemedicine blocks or whole telemedicine days. And so we tend not to run late.
I've found, like, in terms of patients, they show up a lot more. There are fewer no-shows when we use telehealth, which has been really nice.
That's great. Let's see, Natasha, it looks like you have a question. Do you want to share that with us?
Yes. My question, I'm not sure the providers will be able to answer it, but I'm old, I feel like, anyway. I have been asking providers to do telehealth and telemedicine for at least a decade, maybe longer. I used to suffer from agoraphobia, and I would always ask my therapist, how come we can't meet over the phone or over the internet? And they would say, it's because insurance wouldn't cover it. And for some reason, insurance wouldn't cover it, wouldn't cover it, wouldn't cover it. And then bam, COVID-19 happened. And all of a sudden, now insurance is covering it. Why do you think they were so opposed to covering it before, where now they're so willing? And has that been a frustration of yours in patient care providing over the years since we've had the ability to provide it, but insurance companies wouldn't cover it?
I think in part, insurance companies started covering it because they didn't have any other choices. You know, like this was what's happening all of a sudden, and everyone had to start making adjustments. And in part, why they weren't willing to before is, you know, change is hard and scary for a lot of people. You know, it's kind of like we didn't. I think, as Dr. Artani was saying, we don't have money measures on the effectiveness as compared to, right? This is a newer thing right now. I can't necessarily speak to the years of frustration, but.
Let's see. What about lab testing? Not all skin infections are staph, not all sore throats are strep.
Really excellent question. So what happens sometimes is that I see a patient on a video visit and I'm like, oh my goodness, that patient needs to come in. I need to get an EKG. I need to IND this abscess. So what we do for our schedule, we keep one slot a day for those emergencies. And then we tell the patient, sorry, I cannot help you through the video. You have to come in. And we can also order labs then. We can do a lot, but then the patient has to come in person.
And then Annie, you have a question?
Hi, yes, it was kind of just answered. My question was just, at what point do you say that you won't be able to help someone over a video call?
Yeah, definitely, absolutely. You're the clinician, you make the decision. For me, it's like if I go home and I worry about this patient at home and I can't sleep, I probably needed to see that patient in clinic or send the patient to the emergency room. So that's for me always how to assess it.
I could say that from advanced nursing too. If I'm really thinking about it a lot, it probably means that person needs to be seen or go to the ER. And there's nothing wrong about calling the patient back and saying, you know, I'm really worried about you. And I think the best decision is I need you to go to the emergency room. This needs to happen, and here's why. And I have never had a patient angry at me for that. They're like, thank you for being honest and for helping me. Let's see. And looks like Paul has a question.
Okay, sorry. See if I can do this. just doing it the first time on my iPad. Not really a question, but I want to emphasize something that I kind of found interesting. I'm a 30 plus year paramedic, literally all over the world, and I'm a pre-profession PA track for UAA. And I forgot her name, starts with an A. I'm not going to butcher it, so I'll just say Dr. A. The first one. She talked about the advantages of being able to see where the patient lives. And I can't emphasize, that's always been a frustration in our, we get that advantage. I can see, as I'm talking to a patient sitting in a chair, I look over at the bed and I see 12 pillows on the bed, thinking, okay, this patient's orthopnic, so that changes my mind. I can look at the table, I can see the foods that's on the table. I can interact in the entire scene and absorb all that information and use that to make my decision about which course we're going to be on. But it's so hard to try then to convince a provider when we get them to the emergency of what's going on, because they don't have the advantage of that information. You can only document so much. It's the being there, seeing it with your own eyes. So I'm just kind of smiling that, that you guys are, that the physicians doing this are starting to see that as such a positive, to see how they act, not just in the doctor's office, come in complaining of, a boo-boo someplace, but actually seeing how they're interacting with their environment at home. And it does make a huge, huge difference. So I just want to emphasize that.
I appreciate that, Paul. Having done emergency visits and home health, I'm so glad that Dr. Artandi mentioned how important it is to see that home environment. It really tells us a lot. Let's see, has there been any boundaries in prescribing medications from a virtual visit? Has it been easier or harder working with pharmacies not being able to physically assess the patient in terms of being overcautious or undercautious in ordering medications for patients?
I wouldn't say that the pharmacists have given me a hard time at all. They normally give me a hard time when they're like, oh, this is not the right
prescription, or there's an interaction, but what you prescribe or why, they don't really care if you see the patient or not. At least that's my experience.
I would agree, and most EHRs now have e-prescribing that you can send a prescription electronically, unless it's a controlled substance, and then you can always call it in.
And somebody said, what about scheduled meds for chronic pain patients?
So we are incredibly strict with our chronic pain medications at Stanford. Patients need to be seen on a regular basis. They need to have drug testing on a regular basis, and we check cures, which is the where you can see all the prescriptions that the patient has gotten for controlled substances. But if a patient is in chronic pain
And is on a video visit and all this has been done, we will prescribe their chronic pain medications with a video visit.
And somebody said here, what about those patients who need a language interpreter or maybe a sign language patient?
And we have a lot of those at Stanford. Initially, what
I did is I did the video visit. I called the interpreter on the phone, and then the interpreter was on the phone listening to the patient and doing it that way. And that worked, sometimes a little suboptimal, but it did work. Now we are a little bit better. Our platform has the ability to have multiple people. So now I can have the interpreter on the screen with the patient and we can all see each other.
And Gloria, how are we doing? It looks like about 1:10. Did we want to break?
Yeah, no, I'm ready to get most of you out. So what I'm going to do is I'm going to assign most of you out to your rooms. And then that's going to kind of leave some of you still here in the main room that I'm still working on. I've got about 3 more groups. I'm very pleasantly pleased to see so many people that are on, but it's taken me a little bit longer to get you guys sorted in interprofessional groups than I anticipated. So just for reference point, When you go out to your breakout rooms, there should be a facilitator there. I'm hearing from Carrie Ann that there might be some folks, Kendra and Lisa, faculty members that might not be able to sit in fully on those groups. So I'm going to try to send a facilitator out to each group, if utilizing our speakers as part of that to fill in some gaps. So please be patient. I'm going to not open up all rooms yet. If there are any more questions, it would be helpful for me to have a couple more minutes, and we will use our full time and do Q&A now versus later.
All right, so we're heading into our groups now.
Like I said, it's going to be some of you are in your group, some of you are not going to be assigned a group yet. So I'll open up the rooms for those, and then I'll work with the others.
Okay.
I'm just going to add, we really appreciate everyone being so patient. This is our first time doing this all over Zoom. So.
I think we're all pretty patient when it comes to any technology stuff nowadays, right? We've all had to deal with all the glitches, and students are certainly used to us, the professors, having issues with our technology. So